My name is Bill Guy. I'm the CEO of Community Mental Health Australia, and I want to begin by first of all thanking the Productivity Commission for this opportunity, and also, as is proper, to acknowledge country and the original custodians of this land, and also to acknowledge anybody in the room with lived experience as well too. Thank you for being here. Community Mental Health Australia is the national peak body for the 8 state and territory community mental health or mental health peak bodies in each one of the states. And through them, we represent 760 NGO organisations, assisting ballpark at the moment about 100,000 people with severe and persistent mental health issues. I obviously should begin by stating that there's not been sufficient time to do a detailed analysis of this excellent 1,238 pages, including references document, and that we will be submitting a more detailed written submission. And at this stage, the best that I can offer in the time we have is a tentative and general commentary on a couple of points. Our original submission to the issues paper began with the statement that mental health is more than mental and more than a health issue. This makes it a complex matter, as the subject matter refuses to stay within a single portfolio and requires outside-the-box thinking to really grapple with the psychosocial ecology of what we presently call mental health. The statement in the report that mental health services are tacked onto systems designed for physical illness speaks to this cross-portfolio reality. The parable most applicable is probably the elephant and the blind man parable, if people are aware of it, where there is 4 blind men, it is a bit gender biased, who are exposed to an elephant for the first time, and one is feeling the legs, and one the tail, one the trunk, one the ears, and one says, I know what an elephant is, it's like a tree, the one that's feeling the legs. I know what the elephant is, it's like a piece of rope, the one that's feeling the tail. No, you're wrong, says the other. The elephant is actually like a giant palm leaf, the one that's feeling the ears. And the one that's feeling the trunk says, no, it's like a fire hose. And of course, the reality is they're all correct, and it takes a long time to come to grips with the elephant. And I'm sure you, as in your role here, have heard many descriptions and important impassioned pleas about various aspects for the elephant. And none of us can at this stage claim to know the full extent of it. So we bring our biases and our perceptions based upon those experiences we've had in life to our understanding. And we neither can escape that bubble that we also exist in. First of all, of course, congratulations for the document and for the wealth of information that it now allows us to mine and trail through in order to be able to reply with a hopefully cogent written response. But it's our initial view that at this stage the report has failed to come up with a new encompassing vision for mental health. As someone once said, you don't invent the electric light bulb by continuous improvement on candles. The dilemma always is, of course, do I design a new house from a blank sheet of paper from first principles, or does one have to work practically with the reality of the Lego pieces that are on the table before one? This is not unlike the rebuild versus the renovate choice put in the report, but rather than applying that choice just to the issue of funding and governance, it would be wonderful if we could articulate choices regarding the broader matter of the whole system design. We will comment more on this in our written submission. What I will say here is that the 3 levels of 1, primary mental health, i.e. shorthand for GPs, 2, secondary mental health, i.e. hospitals, 3, tertiary mental health, i.e. specialists, are all founded on level 0, the ground zero of mental health, which is community mental health, understood broadly as the mental health of the community, for the community, by the community. It's the social and emotional well-being that our wise original owners of this land counsel us to consider as the embracing framework for those that are familiar with the approach that has been taken in many Indigenous communities, but also in the Australian Indigenous community. In this framework, we are social beings, and our individual circumstances and conditions are largely, though often invisibly, the downstream effect of the well-being or otherwise of the communities, including families, that we live, work and play in. It's a systemic approach to prevention and early intervention. This framework includes, but is more than the standard list of social determinants, housing, employment, etc. As the framers of the recently released New Zealand Wellbeing Budget, which I commend to you for inspection, have found, there is not one portfolio that was not relevant, and GDP in the New Zealand Treasury policy document now is only a subset of their wellbeing index, measuring national progress. If people have trouble grappling with this, and it is difficult, that's exactly the point. It's a situation where broad thinking is required, and it's insubstantial and does require some time until you converge critically down onto what specifically is needed. So I apologise if some people might go, what the hell is he talking about right now? So I'll try and be a little bit specific. So as said, there's many positives in the report, but I'll just focus on a couple of areas that we think is missing, incomplete or missing, or incorrect, I should say. Missing, incomplete or incorrect. Firstly, unless we've missed it, the notion of trauma-informed care is not mentioned in the report anywhere except in relation to ATSI services, Australian Torres Strait Islander services there. And in that regard, of course, the current simple mantra of the field and a lot of consumers is, don't ask what's wrong with me, ask what happened to me. And without that perspective, we're missing an important chunk. There's also no mention at all of non-traumatic at-home crisis interventions like open dialogue, though there are now 3 trials in Australia of that particular approach. And that can come from either the community sector or it can become through a revision of the traditional assertive outreach approach there. But the benefit of it coming from the community sector is that there's a different relationship than there is between that and a health authority. And that seems to be a secret component of its success rate in the evaluations of open dialogue. Most importantly, though, the need for a robust non-clinical recovery support workforce is not there. And by non-clinical, I do not mean to put an us versus them implication there. Indeed, that traditional division between clinical and non-clinical is actually probably more unhelpful now than helpful there. There's a service out there run by an NGO service where there's CBT coaching and mindfulness training, as well as everything else, social participation, etc. So the boundary between what is traditionally thought of as clinical and non-clinical now is very blurred. And so to that extent, it may be best to think in terms of what's required necessarily on what, rather than just what sector delivers it. But as I was saying though, what's an important omission in here is that there's no addressing in the chapter on workforce development and elsewhere on the workforce employed, particularly by the NGO sector working in the recovery support area there. Using the figures, there is a brief mention, I should say, of low-intensity therapy coaches, and the peer workforce, of course, is included in there, but not the other. In the PC document itself, it does state that in 2017 there were approximately 27,000 people working for the community managed organisations in the psychosocial services area there. Our view was that it probably should have been closer to about 30,000. By comparison, in 2017 there was 3,369 psychiatrists. Again, not that it's an us and them, but just to give you a sense of the scale and difference there. As I'll mention in a moment, the community sector has been through its own traumatic transition in a little while, which has been quite damaging, and it was an example of poor change management. And we have lost a significant degree of intellectual capital, and that's a shame. because it had grown very well over the last 15 years, and a lot of taxpayers' dollars went into that. And I think, as I will mention, it was probably based on some overly rosy assumptions of the transition rate that people would go into the NDIS. And because of that, a number of people have left the sector. There's been restructures there, and probably somewhere in the order of 10 to 15,000 people with severe mental illness have disappeared back into the woodwork. That took a long time to contact them, which is a bit of a shame. Now, the workforce this workforce is very important, and their ongoing skill development is vital to a future society with improved national well-being, and particularly for the most disadvantaged. And the workforce needs can be worked back from three principles. One, if you clarify the outcomes needed specifically for economic and social participation, and maybe even measurable self-efficacy measures, that will in turn define the competencies that you need for those outcomes, both inside and outside the NDIS, because this is also a matter for inside the NDIS as well too, in that we don't want to just maintain people through care. We want to teach people to fish rather than give them a fish. And that's an important difference between a lot of people's understanding of what people either with disabilities or mental health need versus for those that have lived and worked in that area know is actually required. That's not to say that the workforce has those competencies now. Some do, but it needs to be articulated and developed, because that will be the way we get those outcomes. And a component of that, of course, is the remuneration needs to be such that we can attract and retain people with those competencies. And the transition to the NDIS has been another great blow to that, in that the average level of worker in a lot of the NGOs has now had to go down from 3.8 down to 1.2. That's between 1 and 2, because organisations have had to shift their financial risk of going broke from their own bottom lines to staff. The casual workforce has doubled as well too, as the Able Insight report recently showed as well too. There was a mistake in Chapter 12, this is a small point, in relation to the transition of the three previous Commonwealth-funded programs. That was Partners in Recovery, Personal Helpers and Mentors, and Support with Day-to-Day Living in the Community. And also there was the Carer Respite program that was also cut at the same time as well too. What's said in the report there, in one place it's correct, in another place it's not correct. I can give you the page reference there. It says that organisations providing those programs were funded to continue those programs for another 12 months. In fact, that wasn't correct. Money went to the PHNs for the extension transition, and not all organisations that were providing those were the lucky recipients of that funding, so it was a lot more messy than that. Some PHNs gave little 3-month funding person by person, others were a bit more generous. So that it's just a small error, but I've noted. And lastly, the following issue is described, but a clear solution is not offered. This is probably my closing point, and arguably the most important point, really. And to quote from the document itself, from one of the pages amongst the 1,238 pages in there, approximately 690,000 people have a severe mental illness. Approximately 64,000 of these are expected to be eligible for psychosocial support under the NDIS. While some of the others currently do and will receive psychosupports funded through either the Australian or state, territory, Commonwealth governments. We estimate about 100,000 maybe through those means. There remains a massive gap between the assessed needs and the services provided. So 690,000, 64,000, which is 8% of that in the NDIS. Maybe at best 100,000 currently getting services, and no clear plan for what we do for what's now sometimes called the missing middle, and I'm sure you've probably heard that term. But clearly it's our big challenge, and one that governments will blanch from, because I can't see any other way around it but extra funding and a threat to surplus. But maybe in the longer term we should at least move towards it, and it should at least be articulated, because while the political reality will be that we have limited funds, the long-term practical reality is that we must invest in prevention and early intervention. And of course this funding competes with emergency services and beds, which are always on the front page. And in an ideal world, of course, you would do both. But I still see that the practical reality is these will compete with each other. So my view is that whatever is recommended will be filtered by political compromise. So I would hope that the Productivity Commission, in their prudence, can push forward hard on this long-term investment approach to prevention, early intervention, because the governments will certainly work backwards and compromise for you from that point onwards. Thank you.
Thank you, Mr. Guy. I just have our apologies that we've got one of the programs not quite right. It's more because we do things at that big level, but there are obviously regional variations. One of our difficulties with the community mental health workforce is that it's a really broad category, and we struggle to pick up the variety of job names. There was little consistent or comprehensive data on how many people are doing what and what the measures of outcomes were for consumers. So we're really asking the sector to give us a bit of help with this.
Could do. Now, the great tragedy there was that a lot of work was done over the last 10 years to produce what was the NGO minimum data set, the MDS, and it was ready to go, and what it would have given you through the Australian Institute of Health and Welfare would have been all those particular numbers. Now, you may or may not know that it got up in Western Australia through a portal designed by Strategic Data in Melbourne, and it's still been used by the Commission in Western Australia. It partly got up in Queensland there, but it then faltered and remained in the in-tray of every other one of the states. And the Australian Institute of Health and Welfare, their protocols require at least a minimum of 3 states to submit their data before the data is put up on their national reporting. They've asked for quite a while, just could we have one more state? So because of that, our sector's invisible. It's been invisible, and that was also one of the explanations why I think the transition from those Commonwealth programs that I talked about was not done as well, because people didn't have a clear idea of the size. I won't be critical of the departments, because I know they each have their own stories, and indeed some of those people are my friends, so I won't be too hard on them in their absence. But I still will say I think there was a failure of them to collect the data, to report it and collect it back. There is a sad story of failures that resulted in that. And certainly the sector itself could and should try to do that, but it really should have been part of the contractual requirements over many years to give the decision makers, particularly the principal committee and COAG, those numbers so that they could steer properly. And you also are the downstream, you have the effect downstream of that data not being there. So the best, we can make some guesstimates at the moment right now, but I can see that when you would have been collecting, trying to look for hard data from the usual resources are not there. But it's still there, and happy when we will do our best to report that data as best we can.